Good afternoon. Thank you for taking part in this very important effort to promote the health, safety, and independence of older adults in our nation. The title of this discussion describes a crucial part of this effort. Healthcare truly is the wild card of retirement security. Even with careful financial planning and thrifty habits, seniors may face great difficulties in dealing with certain costly illnesses and conditions. One disease that exacts a particularly high toll on seniors, their families, and our society is Alzheimer's. As a senator representing the state with the oldest median age and as co-chair of the Congressional Alzheimer's Task Force, one of my highest priorities is increasing federal investment in biomedical research. Alzheimer's is our nation's most costly disease. Although promising research is underway, there currently are no means of prevention, effective treatments, or a cure. The good news is that the Appropriations Committee, on which I serve, recently approved a 60% increase in Alzheimer's research funding. I'm delighted that the Senate is finally recognizing the need for a greater investment in Alzheimer's research. A national plan to combat Alzheimer's and other debilitating conditions must include assistance for family caregivers on the front lines. The Raise Family Caregivers Act that I've introduced with Senator Tammy Baldwin would help us to leverage our resources, promote innovation and promising practices, and provide our nation's family caregivers with much-needed recognition and support. The Senate Aging Committee, which I chair, is committed to addressing the crisis of declining retirement security among America's seniors. There are many reasons for this decline, including the demise of many defined benefit pensions in the private sector, the severity of the recent financial crisis, and the simple fact that Americans are living far longer than we did in the past. As we confront these issues, we must do all that we can to counter the wild card of devastating diseases that deplete a retiree's savings and financial security. I hope you have a terrific conference. Thank you.
I'm sure you are familiar with Senator Susan Collins' work. She wanted to be here in person, but had a commitment, and we're very happy that she could be with us by video. We're going to hear from Congressman Chris Smith in a couple of minutes. He's, I think, just pulling into the parking lot, and he has introduced the companion legislation in the House of Representatives to, it's called the HOPE Act, to Senator Collins' legislation in the Senate. So now they've asked me just to stall here and talk for a few minutes, so and until he walks in, you know, the reason I asked Senator Harkin the question about means testing, you all know what that means, right? Anybody think it's a good idea? I don't either, but if you follow the presidential campaign, there's a governor from a blue state, East Coast blue state, a big guy, I'm not going to mention his name, but he's for means testing. You've heard that, right? He's for means testing. Social Security. He gave a speech in New Hampshire, and he said if you are eligible for Social Security and you have income of $200,000, you shouldn't get your Social Security. Now that, to me, is a surefire way to destroy the program. Why in the world would someone support a program, and if they end up doing pretty well, they don't get their Social Security? It doesn't make any sense. And we have done everything we can to put our spin, our side of that debate on means testing out in the media. And I think the public is with us. You know, the reason people support Social Security is people pay into it, and when they reach eligibility, they receive the benefits. It's an earned benefit. You agree with me? Yeah. Okay. I see the congressman walking in, so I can stop stalling. By the way, I have talked with Senator Harkin and members of Congress all over the country, done town hall meetings, and here's the best way I try to get the message across. I ask an audience, how many of you are on Social Security? Almost every hand goes up. And I say, how many of you are ashamed to be on Social Security? Well, nobody's ashamed to be on Social Security. And then I say, how many of you would be proud to be on welfare? Nobody. But that's what means testing, as the senator said, turns Social Security into a welfare program. Now that I made those comments, it's my pleasure to introduce Congressman Chris Smith, who's a representative from New Jersey. Welcome, Congressman. He represents the 4th District of New Jersey in his 18th term. He's been around for a while. He knows what he's doing, and he cares about what he's doing. And our first panel this afternoon will discuss the importance of health care to retirement security. And we invited the congressman to join us because he has been a tireless advocate for people with life-threatening illnesses and challenging disorders and diseases, including Alzheimer's. It's a disease that really poses an immediate and a direct threat to our health security because of its growing human and, of course, financial costs. Congressman Smith is a leader in the battle against Alzheimer's. He's partnered, as I mentioned, with Senator Collins. Congressman, we just played a video presentation from the senator talking about your bill and her bill, the HOPE Act, Hope for Alzheimer's, which for the first time would provide Medicare coverage for case management planning to help people who are newly diagnosed with Alzheimer's, and would help, of course, their families. Congressman Smith has led the fight to expand research on autism. He chairs the subcommittee on Africa, global health, global human rights, and has repeatedly called for investments to fight AIDS and other diseases in Africa. He's a champion for these causes, and we're honored to have you speak to us. Thank you.
Appreciate it so much.
Thank you, Tom.
Thank you for that very kind introduction, and good afternoon to everybody. Just a few opening comments, and I'll keep it brief. I learned a lesson. I used to chair the Veterans Affairs Committee and did a number of bills that became law dealing with health care, particularly for those with polytrauma. And I was at a conference at the VFW just recently talking about health care, and there must have been 1,000 people there, a lot of them with their families. And I said, how long do you want me to speak? And they said, well, you got an hour for the keynote. And I said, an hour? That's a long time. I'll take it. I spoke an hour and 5 minutes. At the end, this little girl came up, because again, there were a lot of families there, and she looked at me and she said, you know, mister, your speech was long and boring. She turned around and walked away. A few minutes later, her father came up and said, I saw you talking to my little daughter, Melissa. I want you to know she's 4, and she just repeats whatever she hears. So every bit of comments and remarks and speeches, including keynotes ever since, have been 10 minutes or less, sometimes 5. So it is such an honor to be here to follow Senator Harkin, who has done so much on the healthcare front, landmark work over the decades. And of course, Senator Collins and I and people like Ed Markey and others who have worked to establish these congressional task forces, House and Senate, on the issue of Alzheimer's. We have 242 members in our task force on the House side, people on every committee, and that's important because you have a lot of people who then can raise these issues in their respective jurisdictions. And recently we saw Tom Cole, who's the chairman of the Department of Health and Human Services Appropriations Subcommittee, add $300 million to the Alzheimer's NIH fund. It has not become law yet, but it is a great indicator that we are very serious about combating this horrific disease called Alzheimer's. 5 years ago, NIH spent $448 million. That has gone up by about $200 million to $638 million. And if we get anywhere near the Cole number, Congressman Tom Cole, we will be looking about a $300 million increase. And we know from NIH that so often laudable proposals fall off the table, are never funded simply because of inadequacy of monies that are going into this. So this will be, I think, potentially a game changer. As you all know, I think, Alzheimer's affects about 5.2 million people in the United States. And that number is expected to grow to 16 million unless there is a change, but by 2050, unless there is a change in that trajectory. While the causes and progression of Alzheimer's are not well understood, research, especially that has been funded by NIH, indicates the disease is associated with plaques, as you know, and tangles in the brain that begin to develop 10 to 20 years prior to a recognition of the disease. Early onset, about 30 to 60, it is believed that a genetic mutation is usually the cause. Late onset, it's a complexity of issues, including genetic, environmental, and lifestyle factors, among other things. Current treatments, as we all know, and we're all desperate for a treatment or a way of delaying the onset of Alzheimer's, deal with symptoms mostly. We have not had any breakthroughs yet, although I do believe it's a matter of when and not if that happens. The cost of Alzheimer's to Medicare and to Medicaid is about $154 billion, and it is growing, and it's almost growing exponentially. There's large costs that are never calculated, and thank God they're there to provide it, but so many family members and caregivers, wives, husbands, daughters, 2/3 of the caregivers turn out to be women, have made an enormous difference in not only the lives of the patient, but also the issue of depressing what has to be expended by governments in order to deal with those who are afflicted by this disease. You know, David Cameron, the Prime Minister of the UK, convened the G8, as you might recall, in 2013, and it was really, and I held a series of hearings on it in my Global Health Subcommittee. It was great to see the G8, and then by extension the other nations of the world, rally behind a target to have a cure or an effective treatment by 2025. The European Union has probably double the number of Alzheimer's afflicted patients than we do. I work with a number of parliamentarians. I'm the head of delegation of the Organization for Security and Cooperation in Europe. So we meet frequently with members of parliaments, including their speakers, including from Russia, from the Duma, and I'm always bringing up health issues, including and especially Alzheimer's, and the need to better coordinate and to work together. In its number of hearings that I've held on the global Alzheimer's issue, and I do work on a number of issues. I have a major neglected tropical diseases bill making its way through the Congress right now, but Alzheimer's is something that has, with some predictability, again, unless it's a game changer. There are about 46.8 million people worldwide, according to Alzheimer's International, and that number will double every 20 years unless we find those game changers that we're all looking for, and that will rise to about 131 million people by 2050. The catastrophic impact that this will have on healthcare systems, including our own, but others as well, cannot be overstated. Some will collapse by the requirement and the need to provide the care and the lack of resources to do so. I've introduced a bill, and it's called the Global Brain Health Initiative, and it focuses on a neglected part of what we're trying to do globally, and that is to deal with dementia, including and especially Alzheimer's, the issue of autism. I wrote 3 autism laws, including the original law back in the year 2000 on combating autism. But it is a worldwide pandemic, if you want, of that developmental disorder occurring as we meet around the world. In Africa, it's tens of millions of children who have autism, and it's largely neglected and under-focused upon. And then, of course, the third part of this bill would be dealing with Alzheimer's. The other one would be with hydrocephalic condition, which is also rampant in Africa. Now, this bill would seek to replicate some of the gains that we saw with the HIV/AIDS pandemic when a global fund was established, which has had tremendous impact on mitigating that disease, coming up with best practices like mother-to-child transmission. This legislation, which is pending in my committee, and we hope to mark it up very shortly. I've been trying to get USAID to support these initiatives as well. We'll say we need a coordinator at HHS to work these issues. We need a global plan. The World Health Organization has done volumes of work, wonderful work, on dementia worldwide, but there is no action plan. The G8 plan is about as close as we get, but there's no systematized effort to say, what are we doing to collaborate with country X, Y, or Z on this terrible dementia known as Alzheimer's. And the legislation, again, will seek to do all of that. We lay out in the bill all the different aspects to it, and it's the who, when, where, why of the entire thing, from respite care for the caregivers to research, clinical research, regulatory issues that might retard the ability to get better drugs to market in a faster way. As you know, the House has passed a bill called that is designed to accelerate the bringing to market drugs based on, hopefully, their efficacy as well as their safety. So we all need to be surging, I think, on a number of diseases, and this is certainly one of them. So that bill is pending and hopefully will soon be passed. We did pass a bill, and it was with the Senate and the House working. You hear all this lack of bipartisanship. Well, not so on this issue. We work across the aisle. Ed Markey, who co-chaired the task force along with me since 1999. I mean, there wasn't the slightest distance between us as we worked together across our parties. And like I said, we have 242 members now in the task force. We did pass a bill in 2011 that created a very effective, it was called the National Alzheimer's Project Act, or NAPA, and the idea there was to quarterback the efforts within the U.S. government, again, so we get better outcomes on all of this. And I do think that they're meeting again on Monday. So there's good progress being made. There's also, and I know my colleague from the Senate probably mentioned it, but the Health Outcomes Planning Education, or HOPE, for Alzheimer's Act. Many people don't realize, but about half of the 5.2 million people of Alzheimer's never got a diagnosis. So the idea of trying to do something to ameliorate this earlier on has not happened in their cases. It often goes many years before it is discovered. The legislation will provide for a planning process so that families can find out more what is available, what they might do, what their course of action, and that would be funded via Medicaid. care. Finally, there's a bill and an initiative that I first learned about, even though it's been around for decades, but there was nothing in New Jersey about it, called the Program for All-Inclusive Care for the Elderly, or PACE. It is an absolutely extraordinary initiative. It's in 31 states. It ought to be in all 50 states and the District of Columbia. But the idea behind PACE is that if people are Medicare, Medicaid eligible, if they are eligible for a nursing home, in other words, they show every sign that that's where their next step will be, this program seeks to keep people in the home. And patients who 55 or older, who again are nursing home eligible, have the program, and there are several of them. There are 5 in New Jersey. The first one was done by St. Francis Medical Center in Trenton. They have well over 300 people, all of whom could be in nursing homes right now, who are now getting adult daycare. They come out every single day that they would like to. Their care is quarterbacked by a group of highly qualified personnel to make sure they take their meds on time, that anything that's seemingly going awry is quickly seen and addressed. And it is helping, leading to healthier outcomes, and it is saving a bucket of money for the government. So it's an absolute win-win. We just opened up a brand new one in Monmouth County last week, and the hope is there that, again, hundreds of people will benefit from this PACE program. And any of you who would like, it is worth checking out for your locale if you don't have one. The risk is assumed by the provider of care. They get a capitated amount per patient, and then, you know, if it exceeds that, they pay for it. If they end up in a nursing home, there's also a liability there borne by whoever runs that program. And what has happened, though, has been it's remarkable. I frequently go to the one at Life. It's called at St. Francis Medical Center in Trenton. And I go table to table, I talk to people, I spend hours there. The joy that these individuals have, they feel useful still, they're socially connected, particularly by going to this adult daycare every single day, and they are healthier, and it's all empirically proven. So PACE, well, this past week, we passed a bill, passed the House and the Senate. I was the prime sponsor of it on the House side, although we took up the Senate bill. They passed theirs first, so it came to the floor. And what it will do is say 55 or older, the chronological age of 55, really doesn't tell us all that much. If somebody is nursing home eligible at 54, 53, or they're one of the 200,000 early onset Alzheimer's patients who need care, and you want to try to keep those folks out of a nursing home, it's for them now too. And we know the president will sign it. So this new change, I think, this will make a big difference in addressing people who have numbers of disabilities and that would require a nursing home otherwise. So it's and that should be signed into law probably early next week. I want to thank you. We're going to push very hard on this global health initiative, global brain health initiative. It's my belief that this is a winnable fight. I remember when the HIV/AIDS pandemic was rearing its ugly head, and the worst case scenarios put out by WHO were just off the Richter scale. It was the Black Death of European times. And I'll never forget, Congressman Henry Hyde, the prime sponsor of that bill, even said that. He said, you know, no matter what we fund here, this has to be funded. This is the equivalent, potentially, for the world, especially for Africa, of the Black Death. And a bill was passed through with his leadership and George Bush's push, and now about $5 billion is spent every year, and of course tuberculosis and malaria are hooked into that effort, again, to try to mitigate those diseases. So we need to do the same thing on global Alzheimer's, because it is a tsunami that we are already beginning to face. Thank you so very much.
please welcome to the stage our panel for the afternoon plenary, Healthcare, the Wild Card in Retirement.
All right, we are going to get going. We have, I am so privileged to be trying to moderate a fabulous group of speakers. I do have their bios, so I'm not going to spend much time on their bios. I will tell you that we have with us Dr. Valerie Coach, who is at the end. We have Judy Fader, also Dr. Fader. We have Rosemary Gibson, who's right here, and we have Kara James, who is in blue and comes to us from CMS. You have their bios. I'm really just going to get right to it because we have a lot of really interesting things to hear this morning. I'm also going to set some context for you, not that this group needs context, but I do think it's important. I'm going to really elevate the issue of health care and retirement security. We heard Senator Harkin talk a lot about Social Security and SSDI and also about Medicare, but just to state the completely obvious point, retirement security is inconceivable without good health coverage. Absolutely inconceivable, and I think this panel will help connect the dots on that point. Why? Health problems rise with age. The probability of needing costly care rises with age. Income declines with age. And while all of this affects all of us, or most of us, it disproportionately affects certain groups of people. It disproportionately affects people of color. It disproportionately affects people who are women. And it is an issue that deserves our attention. So let me just hope this works. Okay, those are our great speakers. Today, what are we going to talk about? Who is falling through the cracks and why? Is Medicare the wild card in retirement? And if so, why? And what can be done to bolster retirement security through the healthcare lens? So to set this up just a little bit, and I know you've heard a lot of numbers today, but I think it's kind of important to show you what the situation is now for people on Medicare. Half of all people on Medicare have incomes of about $24,000 or less. When I'm in discussions with people who are policy people, they're really surprised by that because so many people that they encounter earn so much more. It's a really important and an obvious point because people on Medicare are managing on these incomes, and yet they too have other financial concerns and obligations like rent and mortgage and food and transportation, and sometimes helping their grandchildren with education or other expenses. You can see differences by gender, you can see differences by age, in particular by age as you see income declines with age. Similarly, half of all people on Medicare have about $64,000 or less in the bank. I think you're going to hear from Dr. Fader, who's going to talk about long-term care expenses, and I can tell you that $64,000 doesn't really go very far, and again, you can see disparities by gender and by age. I'm talking quickly because I really want my panelists to have plenty of time to speak. This is really important. We looked at Medicare, we looked at income over time, because what I wanted to see is, okay, so is my generation going to be a lot wealthier than the current generation of people on Medicare? Can my generation afford to absorb more in terms of health care costs when my generation retires? Answer, no. If you look at these projections, what you see is median income creeps up a bit, but not very much. Really, the major gains happen toward the end. Very quickly, what are some of the issues? Well, Medicare has a drug benefit, but it has a gap. Medicare has no out-of-pocket limit, as most employer plans do. Medicare doesn't cover routine dental or other dental services, almost inconceivable for an elderly population. No eyeglasses, no hearing aids, no long-term care services and supports. So people incur a lot. This shows you out-of-pocket spending rising over time. Here you can see, this looks at the distribution of out-of-pocket spending, and to our surprise, we saw that people in Medicare are actually spending a lot in premiums, which we hadn't anticipated, but when we break it down by services, what you can see is long-term care is a big expense, as is dental. And while everybody, I think, thinks of health care as a major issue in terms of their economic security, it is important to say that people who are on Medicare, people who are retired, bear a greater burden in that health care absorbs a larger share, 3 times the share, of their household budgets as it does for younger households. So to get our panel moving, I see some troubling trends. Fewer and fewer employers are offering retiree health benefits. That exposes workers to higher costs. Actuaries are projecting a pivot, an upward pivot in healthcare costs. That affects the Medicare program. It also affects people who will be paying more and more for their health care. Income inequality and savings inequality is an issue today, and it remains on the horizon as far as we can see, which means we don't have a rosier picture unless we take some kind of action. And finally, there are no real serious policy options that are being discussed that will actually help fill these gaping holes. So with that kind of dark and gloomy intro, I'm going to turn it over to, I think we said, did we say Valerie would go first?
I'd be happy to go first.
Okay, thank you.
Great. Well, maybe we should have brought some antidepressants to this panel, but we'll hopefully come up with some solutions as we go through. Good afternoon. I am Valerie Coach. I'm so pleased to be here this afternoon and want to thank all the folks at the National Committee for inviting me to join you. I'm here today wearing several different hats. Most fundamentally, I'm a physician. I practiced medicine for over 20 years in Philadelphia. I'm also a senior policy advisor at the National Physicians Alliance, which is a nonprofit organization dedicated to making sure that everyone in this country has access to quality, affordable health care. And most recently, I'm an elected official in Montgomery County, Pennsylvania, which is the county that borders Philadelphia. It's a very large county, over 816,000 population. And although on average it's a wealthy county, we have pockets that are extremely low income. So we are dealing with these issues on a regular basis. And I want to offer 3 general thoughts about what we face today, and some simple solutions and a more complex solution. First of all, I think that we need to do a lot more in education. And when I say that, I mean both of consumers of medical care as well as of providers. One place that we need to provide more education is in insurance literacy. Many people really don't understand how insurance works, including many consumers. I'm hopeful over time that as more adults gain access to health insurance in their adult lives, they will roll into Medicare with a little more sophistication about insurance. But right now, many people entering Medicare have been uninsured, sometimes for decades. So we have a lot of challenges there. And I can assure you that very few physicians actually understand how most insurances work, or could even tell you what Medicare Part A, B, and D mean. So there's just issues on all sides of that equation. We also need education, particularly for consumers of health care, around health literacy, and more tools to help people understand what healthcare providers are telling them, more tools to arm them with appropriate questions to ask when a provider tells them they need a number of tests or they need to take a number of medications. How does that person determine whether or not they really need that test or that medication? I think we have a long way to go and a lot of opportunities with creating programs that would help to educate people about simple health problems. We also need a lot of education about costs. It's extremely difficult, and I am fully behind every program that is trying to make healthcare costs more transparent, but we've been largely unsuccessful in that effort, partly because of the complexity of our health insurance systems. Physicians struggle with this mightily. Patients ask every day, well, what will that MRI cost? And there's no simple answer to that question. They have to figure out which insurance plan the patient has, et cetera, et cetera. So extremely time-consuming and complicated. So There's another bucket that I think a lot about, and that's our payment policies. And don't worry, I'm not going to talk about physician payment reform. Rest assured. One you've already heard about, that Medicare does not cover some really basic things like dental and vision care. It's very hard to prevent falls in the elderly, a very common and costly problem if the individual doesn't see very well. Similarly, dental care is just as important as any other physical medicine care. If a person can't eat easily, that obviously affects their nutrition, but poor dental health can produce extremely costly and often fatal heart conditions and other problems that are so simple to prevent with good dental care. We are seeing a couple of very specific problems in where I live in Montgomery County. We are seeing increasing numbers of seniors who have unpaid balances from prior hospitalizations who now need new care, but they delay going for that care because they know they have a bill that they haven't paid off from their last visit. So care is being delayed. I would love to explore a way that Medicare could work with our hospitals to help them work with patients to get their bills paid, but in the meantime, continue to offer and provide care if care is warranted. We're also seeing in our dual-eligible population problems with people that are registered in Medicaid in Montgomery County, but maybe cross over into Philadelphia County, where there are many providers of health care, to get some specific treatment, maybe physical therapy, something particularly that's ongoing. Because they're not registered for Medicaid in Philadelphia County, they're responsible for the co-pays for this care, which can often be quite large, and they're unable to pay. They could avoid this by registering for Medicaid in Philadelphia County as well, but almost none of our patients know that they need to do that. And so policies that would enable Medicaid to follow the patient, at least within a state, could do away with some of these annoying and I would think relatively easy to solve problems. So those are just a couple examples of some of the payment reforms that are relatively simple. I know they're not that simple, but relatively. And now here's the one that I think I would love to see us moving toward, but is obviously both politically and from a policy standpoint quite complex. And that is that Medicare has really evolved over time. I think that Medicare has been extraordinarily successful in ensuring health care access for our seniors, and it has gone a long way to protecting so many seniors from financial hardship. When Medicare was designed 50 years ago, we barely had antibiotics. Now we have an incredible reliance on prescription medications and other things to keep people out of the hospital and keep them healthy. Some of that may not be necessary, but nonetheless, people are given these prescriptions. So I would really like to see a robust discussion take place in this country about moving Medicare to a single comprehensive benefit. It would look much more like the insurance that people have had up until the point that they went into Medicare. It would go a long way to reducing the complexity of plans that seniors are faced with trying to figure out which pharmacy benefit, and do they need supplemental insurance, and should they be in Medicare Advantage. These are extraordinarily complex decisions, even for people with a very high degree of literacy in these areas. It would save administrative costs, and I think it's just simply time. It's nonsensical that we've created this artificial division in the program. Doctors are being asked, and rightly so, to put care together, to look at care holistically, to look at outcomes finally, not just the volume of care that we provide, but the actual measurable outcomes of the care that we provide. And not having their patients enrolled in a plan that is very comprehensive and covers all of those things in unity makes it just becomes one more barrier for the physicians to achieve the task that we have been asked to do. Thank you.
Thank you. That was terrific. Judy.
Tricia indicated some of the holes and the limitations to current Medicare benefit. Valerie, you've expanded in that and suggested ways to improve it. I'm going to talk about one humongous hole in our social insurance protections, and that is for long-term services and supports. Not talking about medical care, but talking about the human help that people who can't manage themselves to eat, bathe themselves, dress, live daily daily life. It's that human help, and we don't have insurance for it. We have today about 12 million people who need these services, about 7 million of whom are over the age of 65. And the vast majority of these people, although some are in nursing homes, the vast majority are getting the help that they depend upon from their family members. And that's terrific, but families can only do so much. And when they need paid care, whether it's at home or in an assisted living facility or in a nursing home, as Tricia pointed out, their resources are very limited, insufficient not only to cover the costs of a nursing home, but even to cover, not even, but to cover intensive care in the home. And that's where insurance ought to kick in, but it doesn't. Health insurance, private health insurance, doesn't cover long-term services and supports, and very few Americans have private long-term care insurance, which typically costs a lot, offers limited value, and is subject to premium increases that can cause people who've paid in for years to lose the ability to sustain their coverage. On top of that, insurers are fleeing this industry because they can't find a way to manage the risk and offer an affordable product. On the public side, Medicare, which we count on for so many things, does not cover long-term services and supports. It confuses people that Medicare does pay for, it pays providers, it pays nursing homes, it pays home health agencies, but not for this long-term personal care. It covers largely care after a hospital day or associated with acute illness. Medicaid is the nation's safety net for long-term services and support and is hugely valuable. But Medicaid only comes into play after you've exhausted all your resources in paying care, impoverish yourself, and the availability of its benefits vary enormously from state to state, with lists, waiting lists for home and community-based care, making it challenging to get Medicaid to stay at home, which we know is where people would like to stay. So the absence of public or private long-term care insurance is a market and a policy failure. And the problem with this, or the irony of this, is that the need for extensive, expensive long-term care is precisely the kind of unpredictable, catastrophic risk for which insurance makes sense. You can't save for this thing on your own. You need an insurance mechanism to do it. Now, I want to tell you how I know that it is an unpredictable, catastrophic risk. And that is, I think you would automatically get that for younger people with disabilities, the need for younger people having a disability that requires this kind of help is clearly unpredictable. That's easy. But too many people think that all of us old folks, or all of us when we get old, are going to need long-term care. Not the case. People my age, over a lifetime, half of us are going to die without needing any long-term care, and a small percentage of us are going to spend a fortune, whether it's through public dollars or on everything we've got, on these expensive services. So it really is a distribution. That's what we mean by an unpredictable, catastrophic risk. It's often claimed in debates about what government should do, or what we should, society should do about long-term services and supports, particularly since a lot more of us are going to need it, as we heard about with Alzheimer's, and the fact that the baby boomers, we're getting older. When we get old, some of us will need a lot of service. And the general comment is, people really ought to prepare. Well, you can't prepare, as I said a moment ago, unless there's an insurance mechanism to which you can contribute that will enable all of us to pool the risk and to spread the risk, so that we can contribute something that will enable those of us who need a lot of support to get it. That will require, given what I said at the outset about the essential failure of private insurance to be able to address this problem, that is going to require a social insurance program that addresses long-term services and supports for people who need it alongside or as part of our health insurance program. The benefits, ideally, they'd be comprehensive, but I'll settle for way less. Even a limited benefit can help a lot of people. I have been working on the idea of an income-related catastrophic benefit that would cover people after a waiting period, and the waiting period would vary with people's incomes. That, I'm hoping, would appeal to the private insurance industry, because there would be then a waiting period, a defined hole. They would not have to take on the big risk, the unexpected tail of very high expenditures. It would be a more manageable piece, and yes, people then could prepare and find an affordable product. But that back end, and really the guarantee of support, has got to come from a social insurance program. So I think it is, given the agenda that we have for improving health security, retirement security, this is at the moment a big lift to think about making long-term services and supports a part of our social insurance network. But as a baby boomer, I'm telling you, as someone said earlier, if we don't take care of this in a meaningful way, then our children are seriously in trouble, because we will be moving in right there.
Well, now that sounds terrifying. At least I could see my kids freaking out at that thought. Kara James, who is the Director of the Office of Minority Health at CMS.
Thank you, and good afternoon. I'm glad to be here. I think for a little while I wouldn't mind my mom moving in, but any longer term.
My children and grandchildren love me best.
Yes.